Hello, everyone. Good afternoon. Glad you could join our session here at the New York State Food Summit. We're very happy to be here. My name is Eileen Fitzpatrick. I am the current chair of the Nutrition Science Department at the Russell Sage College, the soon-to-be Professor Emeritus, moving on to some other infant nutrition work, but I'm happy to be here. I have taught community nutrition and community nutrition education for a number of years, and I am happy to be the facilitator for this panel discussion. So I'd like to introduce our panel here. We have a number of practitioners in the field, and I'd like to give each of them an opportunity to introduce themselves, and I'd like to start with Nancy Coffey.
Thanks, Eileen. My name is Nancy Coffey. I'm the community nutrition educator at the Albany Damien Center. The Albany Damien Center is an agency that is primarily a resource center for people living with HIV and AIDS. I have a bachelor's degree in nutritional sciences, and I have a master's degree in health education. I have worked in many jobs or many positions, but I primarily work in community health and public health and nutrition. And I guess lastly, I'm really excited about participating in this food summit, and I hope to participate in others to come.
Great, thank you. And now to Megan Latza.
Hi, thank you. I'm Megan. I work with the SNAP Nutrition Education and Obesity Prevention Program. SNAP-Ed, our role is to support SNAP in addressing food insecurity. And our education piece is a way to help improve nutrition and prevent and reduce diet-related chronic diseases. Historically, we've done direct education, and that has been my love. So for over 20 years, I've stayed with the SNAP-Ed program and done nutrition education with them. More recently, I've become a nutrition policy systems and environmental educator, where we're looking at the influences in the community and places where people work, where people play, where they learn, and looking at what impact that has on people's changes, making healthy behavior changes, and what opportunities they have.
Great, thank you. And Dr. Renee Rodriguez.
Hello, welcome everyone. I'm Renee Rodriguez-Goodemote. I'm a family physician here at the Saratoga Community Health Center. And we have a community medicine model here that is integrated. Our philosophy and mission has been around addressing the needs of marginalized populations. We have been running a Nutrition RX program for the last 5 years and really focused around group visits and using nutrition as medicine and how that can be used medicinally in order to actually avoid more costly medications, a lot of education, and we also have a community farm and community garden that we have a horticultural therapy program for our patients as well. So it's been a wonderful experience for us to have people have experience with nutrition, both from soil all the way to fruit.
Great, thank you. Claire DeSanto, would you care to introduce yourself, please?
Good afternoon, everybody. I'm so happy to be here and honored to speak with these amazing community educators, practitioners. My name is Claire DeSanto, and I started with the New York State Department of Health just pre-pandemic. So I'm new to the field of public nutrition, public health, but I'm loving it, excited about it. What a time to have entered. So I coordinate a SNAP education program called Just Say Yes to Fruits and Vegetables across the state. And it's been really exciting.
Thank you. Thank you.
Thanks, Eileen. My name is Allison. I'm the closer of the introductions, and I am a community wellness advocate at CDPHP. I'm also a registered dietitian. I'm also new to the community health space, though I've been a dietitian for over a decade and have worked with food by other means. I also joined CDPHP during the height of the pandemic in September, and the community engagement team is one of the many branches of CDPHP to really tap into communities live where they work, live, and play in an effort to anticipate and also provide any of their health needs. And food programs here at CDPHP is one of the cornerstone pillars to that end. And I am also very grateful to be here and excited for our conversation.
Wonderful, thank you. So we have a couple of questions to discuss during our time together. And the first question I'd like to start out with is, what approaches have you found to be most successful in your offerings of community nutrition education at the individual, community, and policy levels? So let's start with that. And then, corollary to that question is, how has that changed during COVID? So I'd love for Megan to start out the conversation.
Thanks. So while we're still fairly new at looking at community and policy changes, we've been doing direct education for a really long time. And in our work that we have done with food pantries over the last, I would say, like 5 or 6 years, and the direct education that we've done throughout the community, the biggest thing that we've done is make connections. Those connections that we've made are how we get people to really make behavior change. Everyone knows McDonald's, or I won't pick on McDonald's, but fast food places aren't good for us, but that doesn't mean that we don't want them. So what we work with is having people really get that self-efficacy and really wanting to make those changes. And by making those connections with individuals in our programs, or with somebody that's running a food pantry, or a teacher in a school, we're able to really pinpoint having them identify what changes they can make to live a healthier lifestyle or to provide a healthier environment for the people they're serving. So what's been great about COVID is that we have actually really worked at, we're able to meet people at their homes because we're doing them virtually. So that's one benefit that has come out of COVID, in that people that had transportation issues or childcare issues, or all those barriers that they had to participate in our programs, we're able to still reach them, or we're able to reach them now. The downside of that is not everyone has the technology to be able to participate in a virtual lesson. So we're excited to get back out into the community and offer those face-to-face programs. We're still working on making them as impactful and really making those connections stronger. Because when you're in a class and you have like people talking to each other and sharing their, yeah, I had that same thing, or, oh, have you heard about this place? You can get like really inexpensive fruit there, or they always have like extras. When that happens in a face-to-face class, that's the most meaningful piece of it. So the success there really is about like making that connection and making people feel heard, and that their personal story is what we're really looking at.
Great, thank you. Thank you. And I know Claire DeSanto wanted to chime in on this question also.
Yeah, I think during the pandemic, as it evolved and new information sort of emerged from our state, it was so important to make sure I was on the pulse of, being able to offer and pass along guidelines, requirements, suggestions, that were coming from the top down, and to make sure that our program implementers had access to those resources that were coming out of the Department of Health. So there were so many moving parts, and so really coordinating and channeling information clearly and in clear directions was really important. And then because we were sort of virtual, extremely virtual, and really I kind of am anyway being positioned in the state, not on site with where our program is implemented. It was really good to strengthen the ability to communicate with our grantees, our educators that deliver our curriculum. So it was good to strengthen, that the ability to communicate, pass along important information, and then work together, offer the space to actually develop and pivot and be flexible and see how can we transition to a virtual environment and be effective and relevant, and strong partnerships with agencies. That was key.
Thank you. All righty. So let's, would anybody else like to contribute to that question?
If I could.
Yes, go ahead.
as the family physician here, what I found very helpful, which I encourage, patients and, I call them patients, but there are community members, really having that one-on-one conversation. And instead of listing the nutritional elements, for example, a certain vegetable might have a lot of vitamin A or vitamin C, that doesn't have as much meaning as, well, this can help your diabetes, or this can help to control your high blood pressure, and bringing it within a context that they might be able to understand, but also have control over, and being able to control the outcome of something through the food that they put in their body and have access to it. So we help to provide the access. We bring a bag of vegetables into the exam room with us and go through the items, both dried items and fresh, and explain how it is helpful for the condition that they have. And I like Megan's comment about meeting people where they're at and setting some goals. We usually do 7-day goals, and we do the SMART goal teaching in our group format. I will say pre-COVID, the group is really effective in helping to support one another through goal setting. The COVID has also been helpful with food distribution and getting more healthy food to homes through delivery as a result of the COVID response fund and all of the activities that we had during COVID. So that actually was an advantage. Now, it's also been a disadvantage because some people ate things at home during COVID that weren't always as nutritionally dense. But I wanted to just add in there, bringing it back to how it can actually influence and improve a health and how someone can feel better. That has been pretty effective for us.
Great, thank you. And Allison?
Renee, first of all, that's amazing that you're bringing food into the exam rooms. I love that. To just play off of what Claire said about strengthening partnerships, as most of you are probably aware, as the resources diminished with the pandemic, the need rose, specifically in the food security space. And so one of the things that CDPHP did was take a step back and just proactively seek opportunities to help support the organizations out there in the community who were faced with this increased need, financially, also through like revising some of our programs that were already in existence, like how can we set people up for home delivery? How can we help this pantry do curbside pickup? How can we repurpose the lunches that we pay for in our corporate space to get them to our community partners? A quick point of information is CDPHP took 2,400 lunches and donated them to various community organizations to ensure that people who were either already socially vulnerable or now found themselves socially vulnerable were benefiting from these resources that we already had that we were no longer using because our corporate space was shut down. So it definitely took a lot of reimagining and repurposing and strengthening the existing programs and partnerships.
Allison, can I just ask how you or who you distributed those through, or how you identified those in need?
Yeah, so it was a team effort, and it preceded my time at CDPHP, but I know some examples were like the South End Children's Cafe. We looked at senior centers. If there were any senior members, children's families were kind of like the first focal points for those lunch donations. And we worked with 34 different organizations to get them out there in the community. And obviously, huge thanks to all of our members of team that helped execute that, because there was a lot of moving parts.
Great. And so now you have those partnerships and those connections. So that's fabulous. That's wonderful. Okay.
Can I just say one quick thing about just the COVID and the challenges? And I agree with Megan. A lot of the challenges of just doing they were no longer able to do face-to-face or group classes, and most of us use Zoom or some type of media platform to educate. But one of the biggest challenges for me was finding that my members, my clients, their disinterest in nutrition education as the COVID hit, because their hierarchy was not being met. Like, instantly, the housing was an issue. There were just, isolation. So luckily, I work in an agency that has a lot of resources I could refer people to. But that was I just have to say that was a really big challenge. And during COVID was just trying to just get our members excited about still remaining healthy, and we had grab and go meals that we provide and pantry bags and whatnot, but it was definitely a challenge.
Great, thank you. All right, so the next question is, so we've talked about, what we've done, the successes and barriers we had during COVID, and you can certainly speak to pre-COVID with this next question, but how do you measure success? And this could be, quantitative or qualitative, either way, but how does your organization measure success? And maybe I'll start with Allison, if that works.
Sure. The first thing that I want to state is the programs are only great if people are using them, right? So our first metric of success is asking the participants what they think. We've also taken some great lengths to simplify that process. So we don't want to come out with like a 20 length question survey. We keep it very simple, as like quantity, quality, general comments. It's really important to us that the foods they're receiving are foods they will actually eat, that they're getting an adequate quantity for all of the members of their household. So survey would be the first point to that answer. And then as the healthcare provider in the insurance world on this panel, I feel the need to mention that we do also take a peek at some of the metrics behind the scenes. So it's not just a reduction in claims necessarily. We might actually be looking for an increase in claims to see that folks are going to get preventative visits that they maybe were not getting before. So kind of reverberating that education piece about trying to put the onus in the hands of the participant of like, you deserve food as much as you deserve healthcare. Here are some of the things that we can set you up with, these resources that exist through our partnerships to make sure that you're getting an annual physical, proper dental care, that your children are taken care of. So I'd say those are two top of my list, is just member satisfaction first and foremost, and then looking at some of those behind the scene metrics like preventative visits. Are we seeing claims come through for different lab values? Like, is their blood sugar getting better? Are there dental visits happening? Those are really some of the biggest measures for us here at CDPHP.
Great, thank you. So Nancy, did you wanna add to this conversation? Then I'll open it up to the rest of the panel.
Sure. So the agency I work with and the nutrition program, we think of, there's lots of success. Like, how do you measure success? What is success? So the first thing we wanted to do during COVID was make sure that we retain the members in our program. So that was one way we measured success. And quantitative data, like how many meals are we serving and how many pantry bags are we delivering? Are we losing, what is our contact with our members? Attendance to our Zoom classes, are they still participating in the education part of our program? I also loosely did or tried to conduct pre and post tests to make sure that members were retaining the information that they would receive during my classes. Attrition, were people were disenrolling, were losing them, and just like was mentioned before, clinical data, looking at taking into account their goals, if they're diabetic or whatever their situation is, looking at their blood sugar levels and their BMIs and whatnot.
Great, thank you. Would anyone else like to add to that question? Renee?
Sure. We've been through this for several years, and it's hard to measure success with health metrics over a growing season. And we use CSA, and we work very closely. We've worked with the Patroon Land Farm through the Regional Food Bank and our community farm here in Saratoga, Pitney Farms. So we've kind of had a short-term and intermediate and then long-term kind of forecast around measurements for success. So one would be engagement, which is what everyone else is talking about. And we have Mediterranean diet food bags that have, again, dried and fresh items in it. It's based off of the Mediterranean diet. So we can very easily keep track of how many of those packages are going out into what households. So that would be immediate and very easily attainable and measurable. And then for, we've actually settled on a readiness for change scale, and we've also used a chronic disease self-management tool. And those are really targeting more thinking and health behaviors. So getting a lot of the group visit dialogue starting to really incorporate into changing behaviors and thinking about changing behaviors. So we've used that. And then certainly something more long-term like a hemoglobin A1C or diabetes metrics and BMI, those are really followed over time. And that's really what we've kind of settled on. And it's important to communicate that to members when they come in and participate, because we want reasonable goals to be set and expectations, and we want people to really feel successful over any decisions that they're making on their own toward their health. So we use a lot of those shorter based ones because we can show people improving and having their readiness for change scale go up and some of their 7-day goals. That's very tangible within a 12 to 16 week period. And then the more long term, our providers will then go through those health metrics over time, usually every 3 months, and that's where then they can work on that. But we want to create levels of success.
Renee, can I ask you what the source of your food is? I know you talked about the regional food bank. Are you, is your organization a member of the regional food bank and you used CSAs? If you could just speak briefly what the source of your food is.
Yes, so we initially had a grant through the United Way, and that grant helped to provide, and we wanted to, whenever programming we did, we wanted to support like not-for-profit organizations with similar goals and missions. So in order to help support the sustainability efforts of the Regional Food Bank, they have the Patroon Land Farm, and we used that grant money to purchase those CSA shares through the Regional Food Bank. And then we used our dietitians to develop the Mediterranean diet curriculum. And we have free labor with our medical students. So we have the education component that is specifically targeted toward the medicinal qualities of food. So the education piece we provided. The United Way gave us some seed money. Our hospital foundation also gave us seed money for purchasing the CSA shares. And now what's nice that we're so many years in, we actually have patients who are giving back or paying forward. So they're volunteering on the farm. Like here we have Pitney Farm, and then they will help to pick out of the Giving Garden, which then will be able to bring produce back. Certainly that would be challenging to do in year one, but now that we're several years in, we can kind of build in a bit of a cycle with that.
Great, thanks.
I just want to chime in quickly that I was one of those unpaid laborers during my dietetic internship, so I can relate. And you actually brought to light something I just want to chime in quickly because I know we want to move on. To your comment of like participants reinvesting in the programs, we have a partnership with the Glen Falls Farmers Market where folks can receive vouchers to spend on healthy food at the market there. Which is one of the many ways that we rethought the delivery of our food to our members. But we have a family who used to benefit from the farmers market program vouchers who are now a market vendor, and they have a small farm that they make food and sell at that same market, which is just another beautiful story of things coming circularly, of putting people in touch with the right resources to help them get ahead, and then them taking on the autonomy to do what is best for their family.
Great, thank you. Yes, I'm unmuted. Okay, so the next question I put to the group is, how do you ensure diversity, that includes cultural, socioeconomic, and any other form of diversity, as part of your nutrition education approach? So I believe, Renee, you wanted to start with your response?
Yes. So yeah, diversity can include lots of things. We do have a culturally diverse population here, and we have our group visits. Again, I'm talking now that we can have group visits again and without COVID. We would do them bilingual. So we would have staff, and I actually help with the group visit series. and it's completely mixed. It's been fantastic. So we have participants who feel more comfortable speaking in Spanish, and they'll add and volunteer their comments in Spanish, and then it's really, you just weave it into a conversation, and then I usually will translate it, but put it, you know, in a conversational aspect within the group. And then there's a lot of dialogue there. What's also really nice with having a mixed group is that we can really talk a lot about different ways of preparing food and how culturally food can be viewed and prepared. I'll give you an example. The food pantries have a lot of dried beans, and we got a very generous donation of dried beans. And our Latino patients actually, if I gave them a bag of dried beans, they already knew what to do with it and how to soak the beans and how to prepare them and things like that. But they were great teachers to the group for our folks who didn't know what to do with dried beans and how to prepare them, and the fact that they can be cooked and then frozen, and different recipes. So they actually shared recipes. We also talked about our historical cultural influences and how we view food, and the types of ways we actually eat and share together. And there's actually more commonality than differences, but it's a really nice way for the sharing of diverse cultures within a group segment. And then we also have an integrated model here that has addiction medicine, behavioral health, and primary. And I mention that because we have many with chronic mental health conditions, and they're a particularly vulnerable population with respect to health. And nutrition's particularly important and probably grossly overlooked in those populations. And it's been a wonderful, very grounding experience for them to be able to be in a group format, but also kind of woven in and be a part of that, so they can kind of practice some of those social skills, but also learning and participating and just listening. So we really encourage a lot of diversity, but we actually don't separate it. We really make it all together.
Claire or Megan, would you like to comment?
Sure. Coming off of our last discussion on sort of understanding our audiences or measuring success, definitely we have our participant survey that we provide at the end of our workshops. And this allows us to better understand sort of the demographics, and then how the information is intended to be used, how valuable the information may have been. And so the surveys, I think, allow us to better understand who we're speaking to, so that we can then, as a program, train our educators on being knowledgeable of those communities, of the special sort of differences in different community settings, so that our reach and the sites of the locations that we're implementing the program, that they can be as diverse as possible and have as broad a reach as possible. Where there's a need, that we can step in and be there to offer wholesome information.
Megan?
Yeah, I agree that training, so staff are aware of what the differences are. That was what I was going to say too, because it's very important to not just put forth, okay, well, this is what I'm familiar with, this is what I know, and even going through, school and knowing everything you can from a dietetics program, you still sometimes are unaware of the differences, and that you do think a certain way because of the way you were raised, because of what experiences you have. So it definitely, when we were putting together a lot of our virtual presentations where we were doing PowerPoints, we could see a lot of areas where it's like, okay, we're picking foods we like. So we need to work better at finding a better representation of our audience, and that those are things that we're using. So it's not just because we're saying it, and we've always been very, inclusive, and we've always, like Renee was speaking to, ask people to share their experiences and to teach each other. But in the PowerPoint thing, we found, okay, but we're visually not doing it yet. So we had to work on that a little bit more. But that training of staff and just having that cultural awareness always in the forefront is a very important piece of that.
Great. Any other comments?
I was just going to say, and financial. I know, obviously, as a dietitian, we love to say, make everything from scratch, buy fresh foods, turn it into tomato sauce. But if the family can use jarred tomato sauce as a means to eat vegetables in like a primavera scenario, we wouldn't want to discourage them from doing that if that's what they have access to.
And I just want to add what Allison just said. We have a diverse population, but I deal mostly with how diverse they are in their needs. And as far as nutrition, do they have a kitchen? Can they prepare foods? Do they know how to prepare food safely? Do they have transportation? So I try to access the food we deliver and the food we prepare and the education to have diverse, how diverse their needs are. So what emergent need is theirs at the time.
Thanks. And one of my primary issues that I focus on in teaching community nutrition to undergraduates is literacy. The reading level of materials. I still find materials that are out there in community nutrition education that are too high a reading level for our low literacy populations, and I think that that's something that we sometimes lose track of, in addition to all the other things we have to think about, in preparing nutrition education for communities. So I like to highlight that, and also health literacy, which I'm sure at the health clinic is also an issue. So ensuring that you're communicating in a way that's appropriate for the population. All right, so let's move on to the next question. We have another. How can food distribution sites assist with, and I added support or help provide nutrition education? So how can these food distribution sites help with that? So either this from personal experience or certainly for a recommendation, looking for any of those. Whoever would like to start the conversation, you're more than welcome to.
And I know that I'm going to hand it over to you, Megan, so you just wait. I was going to say, through one of our models that has been a work in progress, and we've found that a great strategy is partnering through organizations such as the Cornell Cooperative, who have bountiful resources related to education. An important note is during this pandemic that face-to-face time has been cut short, if not eradicated entirely. So we've had to change our modality for education in thinking of technological solutions, sure, but as Megan mentioned earlier, sometimes technology is a barrier. So writing really thoughtful, concise literature to include with any package that we're delivering to members of our community. Those would just be some of the things. And I'll hand it over to Megan because I know we've worked closely with all of their resources at Cornell.
Thanks. Yeah, I would say that, partnering is probably one of the easiest ways to do it, because if you can partner with somebody to sort of take that education piece off your hands. But in addition to that, there is support that can happen at food distribution sites, at those other sites that are both going to help that consistent message be in multiple places. So if they're only hearing it from me or one of our educators throughout the state, that's one place. If they hear it slightly different somewhere else, or they hear a different message or have somebody else giving them something, then there's so much information that it becomes confusing. So if there's a way, if anyone went earlier, I think Sarah had put slides up about, all the arrows are pointing in the same direction. That is, that's our first step. So if we're all sharing the same message and the same verbiage in the same way, then it starts to just become norm. So working with the Just Say Yes program, working with Cooperative Extension, your SNAP Ed program, or whatever local programs you have to sort of help make those messages consistent within the pantry. If you don't have time to do separate nutrition education, is another piece that you can do in addition to having us come in. And I'm not sure about Claire, but we are offering a lot of virtual classes. So it used to be, we've done programs at pantries before, and we would be there on that day, and whoever was there that day participated. But there's every other day that you're serving clients that we aren't able to reach those people. So these virtual classes are actually opening it up where people might have more access to our programs. But yeah, definitely partner and find ways to have that consistent message. If it's training for your staff, if it's posters that you have up, if it's something that you're putting in the bag, so they're getting that message that way. Those are all ways to encourage that nutrition education.
And I'll just follow up with that just briefly. I think the behavioral economics, the nudges, making it easy, making it look appealing, making it look more, so for the food pantries, a little bit more like the grocery store, using, language that's encouraging. I think that makes a huge difference. And so that, would add to that consistent message, that support. And it's a little bit more subliminal than, directly in your face. So would anybody else like to add to the conversation?
Just a thought sort of on the tail end of that, sort of changing the environment to encourage consumption of, and clients taking healthier foods. It's just been some interesting conversations considering what will happen in this post-pandemic period if some locations choose to not go back to their more traditional operation, if they actually feel that how they've modified their distribution is working well for them. It's just interesting conversations to think about sort of that, how do you maintain the choice for the client, to be able to visually or in different ways nudge in if someone's not actually in the location itself seeing the food in front of them. So that'll be really interesting to see what we can come up with collectively.
I've heard that a couple times throughout the summit of the item of member choice. And I know that is maybe one of the questions that's in the survey that's in the beginning of this.
Yeah, I think I'm on the board of the food pantries for the Capital District, and I think the majority of their member pantries have been client choice prior to the pandemic. And I think it makes a huge difference as far as utilization, as far as the elimination of a lot of the regifting. People got things in their bag that they didn't like and regifting it to the food pantry. And so that people actually get what they would eat and what they can prepare. So I think that client choice is crucial. So I agree with Claire. It'll be interesting to see if we can have that in a modified delivery system. Anybody else want to? Okay, well, I think we can then move on to the next question. And, this is open to everyone. What recommendations do you have for those programs that say they are understaffed and or under-resourced to provide not only the education piece, but healthier options? So for those organizations that are under-resourced, understaffed, what would be your suggestions?
Can I start, Eileen, with just something that I've seen used in for food banks and pantries and whatnot, is to utilize social media, just so that, food pantries and food banks are uniquely positioned to provide food, but sometimes they don't get donated the foods that they need for their population and or healthy foods. So I've seen social media sites list like food drives or whatnot, and be specific about what foods they need. And so that's one of my biggest suggestions. Tie in with farmers and connect with local farmers markets and whatnot, and also ask what farmers do with their gleaned foods. So there's foods that would be perfectly fine to eat, but that might not go to the grocery store, but go to the farmers market. So those are just a few things that I thought of or I've seen.
Yeah, so I know Capital Roots does a lot with gleaning of products, so that's another potential area to pursue. Anybody else?
One of our partners is Comfort Food Community up in the North Country, and they do a lot with that as well. I was just thinking, you have this whole infantry of participants who could kind of function for you as advocates to, kind of like Megan said, is that repeat messaging and getting a consistent message out there, and word of mouth, I feel, is another really great untapped resource to assist in times of reduced bandwidth for your staff. it seems a little cliche, but I keep going back to partnerships, like just leaning on each other, seeing what's already out there that could be leveraged instead of recreating it would be another idea I'd like to throw into the mix.
Great, thanks. Renee, did you?
Yes, I was going to echo what Allison said. There's really no need to recreate a donation list or even educational materials if we have partners that answer the address the need and it's already prepared. So some of it would be just sharing those materials. We've also used our local National Honor Society students. So again, using students in the community that really need volunteer hours and are very highly motivated students, and they have done a giving tree. So around the holidays, instead of doing a Christmas tree with the ornaments for gift items, they will put food items on there. And some of the ornaments are very small, like a can of tuna. So people can donate whatever they have the ability to donate. And then some of the other items might be large, but everything on the back of the ornament is a preferred food for the pantry. And that has been fabulous in us getting really preferred items, but then those students will actually collect the donations, bring them to us for our nutrition resource center, and then they actually will stock our shelves with those items. And part of it is it's really circular again for those students to learn what nutritional items are most healthy and how they're grouped, but it also influences their knowledge on what food they should be eating, because our assumption is if you are of higher means, you may be making the right choices with food, but that's not the case at all. Again, when we get back to that diversity and equity within food, it's really for us to learn from each other larger as a community and as a whole. So even those volunteers are learning as they're giving.
Well, and I'm a big fan of utilizing students. I mean, our nutrition students at Russell Sage have always had a food pantry activity. We did, I think food demos are really important too, as far as helping with exposure to maybe novel foods for some populations or people. So I think that, but utilizing students is certainly a way. And there's all levels of education have students, so high school, college, and even med students have some requirement for community engagement. Any other comments?
Yeah, quickly, we're in an emergency situation, and when that happens, different things rise to priorities. I would say one of the biggest things to do coming out of this is to make sure you have the structures in place. So when you do have an emergency to deal with, or there are higher priorities, that if you have policies and procedures in place to have that nutrition in the forefront without having to be like, oh, that's extra. We're going to do, when we have time, we'll focus on that. It'll help make it easier because there's a plan in place, make it easier to still have those things in place.
Anybody else? Okay.
Yeah, I think being knowledgeable, participating in different webinars, being familiar with your regional food bank, and having strong connections, just to be aware of what's available to you and how it might be able to help alleviate a lot of internal burdens. Just to have the connection and tap into resources to elevate the efficiency of your own operation.
You all took the first step today by attending the food summit, right? To meet the partners.
Okay, and there's a comment in the chat. So this is someone from a food pantry. What we have done in the past is approach colleges. We were successful in getting football and basketball teams to come in and volunteer. As for receiving extra donations, collaborate with larger pantries that have the capacity to bring in more food and other items, and then distribute it to pantries that don't have as much. I know sororities and fraternities also do volunteer work, and so one of the things I wanted to highlight though is that those groups are not necessarily all trained in nutrition. So one of the things I found in working with the pantries was the staff, they're wonderful volunteers, but not all of them understood healthy foods and how to prepare them and things like that. And I know this group heard me say this when we met previously, but don't yuck my yum. That people have specific food preferences and they tend to be negative about things either they don't like or they don't consume. So I think it's also important for, and my area of experience is with the food pantries, but it could also be true at the food bank of that, trying to train staff, basic nutrition, and also, kind of that respect for other people's preferences, I think is crucially important. Anybody else? Okay, I had one final question. I come from a public health background and preparing for emergencies. And how has this COVID experience really changed our ability to endure another emergency? Hopefully not another pandemic right away, but certainly there are other emergencies in other areas of the country. There's fires, there's hurricanes, there's earthquakes. We've had ice storms here that have closed northern New York for weeks at a time. So I just thought I'd throw that question out there for anybody to respond. This kind of idea that there are maybe some silver linings in the sense it makes us better prepared for future emergencies. If anyone would like to comment on that. No?
I feel like one of the things that has come out of this for at least my group and for me personally is all these things that we thought, oh, we can never do that this way. We've rethought that we've okay, we were forced. So we came up with solutions to things that we did in a very different way. So I feel like we have that resiliency and maybe we need to think about we can't do it that way might not be the final answer. And that we can look at other ways to approach things and other ways to, make that impact.
Anybody else?
I was going to say partnerships and partnering, using each other and collaborating, pooling resources. Up here in Saratoga, for example, EOC has the primary food bank and food pantry up here, but they didn't have the vehicles to distribute everything. So they partnered with the Salvation Army, who had the vehicles for distribution. So really coming together in short order and really just being less siloed for us, learning from each other. And it's healthcare providers and health systems included, not staying, in a hospital or a health setting, really getting out in the community and seeing how we can help and how we can partner and assist.
Anyone else? Final comments?
I found, I know, Eileen, you and I talked about this, but like Megan said, when COVID hit, we had to adjust quickly like everyone else. We had to pivot how we're going to educate, how we're going to provide meals, how we're going to meet the needs of our members. But I also found that the silver lining is that not only was I continuing to be a nutrition educator, but I filled other roles. As I mentioned before, the immediate need of our members was not really food so much as the isolation, the loneliness. So I acted, let's say I conducted a lot of referrals. I know the community that I work in better than ever. I know my clients and my members better than ever through COVID because we're all going through this together. And I think that it's a little sort of intimate. We're all sort of helping each other out. So I think that as far as like an emergency situation, I'm better prepared because I know my community better and I know my population better than before COVID.
That's a great point, Nancy, is just making sure you're solving for the right problem, right? Like modern problems require modern solutions. And I feel like all of the panel here has mentioned that in one way or another, is getting to the root of what the actual ask is and then trying to come up with a clever way to solve for that, even if it breaks your historical reaction or process. And I also just want to bring back up, just to continue to lift you up, Megan, your answer from previous about getting good policy and infrastructure in place that is routine for your team so that when priorities shift, those things are kind of set and autopilot, rote routine that's something everyone's familiar with so that you can tend to the more urgent issues.
Great, thank you. So I think we're coming to the end of our time. So I guess I will close it here. Does anybody have any final summary comments? I think this has been a great conversation. I think we've provided a lot of good ideas and potential resources to our audience. So snap ed. Yes. Thank you, Megan. Yes. So thank you everyone for being here. It is now 2:50. So we will close the session here. Thank
Thanks
you.
so much.